Hey guys, good morning. Welcome to the first PEM day of the year. So we gotta go like fast forward today. Get seated. Welcome. Because we have a lot of lectures and not a lot of time. So for those who doesn't know me, I'm Nicole. I'm one of the second year PEM Fellows. And this is my lecture for today. When MSK pain is something else. So these are kind of like our objectives. We're gonna go through the first visit, bounce back, of course, differential diagnosis, treatment plan, hospital course, topic discussion, take-home points, and the end, right? This can be like a conversation, so I want you guys to participate to do it like more interactive. The patient gets to the ED. This wasn't this year, by the way. It was like a few years ago. July 7th, 2 p.m. 8-year-old female with history of eczema, recent fit flare, presented with 2 days of left shoulder pain, which is probably worsening. It is located at the left superior shoulder and lateral neck, associated with a fall 3 days ago from a swing. No pain meds were given prior to arrival to the emergency department. The patient denies any headaches, nausea, vomiting, diarrhea, no fever, chills, no numbness, tingling, chest pain, or abdominal pain. So these are the vital signs on arrival. Temperature 100. This is not a rectal temperature. Heart rate 115, blood pressure 120/65, SAPS 100, and respiratory rate 22. On exam, the patient is not in acute distress. She has normal heart sounds. She's clear to auscultation. The abdomen is soft and non-tender. The right shoulder is normal, full range of motion and non-tender. The left shoulder, they documented mild tenderness to palpation over the supraclavicular and paraspinal muscles with full range of motion. Neck, nose, spine, tenderness, and full range of motion. And note exam was also normal, like normal sensation and motor strength on bilateral upper extremities. So given that she had like the recent history of like fall trauma, they plan to do warm packs, analgesia, and x-rays of both the shoulder and clavicle. What you guys think was kind of like the working diagnosis they were thinking of at that time? What else? Synovitis is good differential. What else? Yeah. It isn't, but yeah. Initially, like it sounds like MSK. She had like a trauma, like all 3 days ago. Like vital signs are kind of like okay, and she doesn't look sick. So they were just thinking like probably this MSK pain. Let's get the X-ray. Rule out she doesn't have a fracture or like a dislocation. They get the X-rays. They're both normal. These are some of the views. They repeat the vital signs, heart rate 98, temperature 37.7. So it barely changed despite like analgesia. Pain improved and she was discharged home with MSK shoulder pain. So is it okay to discharge the patient? Like I asked this to myself and I was like, yeah, like she can go home. But then I was like, what are the discharge and kind of like return precautions we should give to this patient? Yeah. And I think this is gonna be like one of the highlights of the presentation today. Like return precautions are super important and they need to be like tailored specifically to the shift complaint and what the patient presented to the AD, like initially. So she came back the next day at like 9:30 p.m. This is the note. 8-year-old female with eczema, brought to fever, lethargy, rapid breathing. She was seen yesterday for shoulder pain, discharged after improvement and negative x-rays. As per mom, patient looked tired. She was complaining of the shoulder and neck pain. She was treated during the afternoon with Tylenol and Motrin and kind of like didn't improve. So she decided to bring the patient for evaluation. She had the fever, she was left shoulder pain and neck pain, and then she was still denying headache, vision changes, nausea, vomiting, diarrhea, cough, shortness of breath, numbness, tingling, chest pain, or abdominal pain. These are the vital signs. When she comes the next day, so 102.8, heart rate 136, blood pressure 104/66, SATs 100%, respiratory rate 28. She was still alert. She was cooperating. She was clear to auscultation. They couldn't listen to any murmurs. On exam, she had neck, left side tenderness of palpation along the sternocleidomastoid muscle. And then they were like documented that she had like specific pain at the level of the sternoclavicular joint, which was kind of like decreasing in intensity as they moved towards the AC joint. She had limited range of motion of the shoulder, left shoulder, ABD and ADD, normal pulses, no motor or sensory deficits. And she also had a rash, non-erythematous rash at the trunk and moderate scoriations of the feet with peeling and areas of denuded skin. So based on the presentation, still complaining of shoulder pain and neck pain, they go in like all in. They're working up a patient with like sepsis. So they get blood culture, CBC, CMP, inflammatory markers, x-rays. They were discussing getting an ultrasound just to see if there was like any effusions. And they were discussing whether to get a CT and not a CT, MRI. So that was kind of the conversation initially. So labs, of course, were altered. She had a white blood cell count of 24 with left side, like with no like left side shift. CMP was pretty much okay, slightly elevated, like anion gap. CK was 230. Inflammatory markers were super high. So CRP was 128. ESR was 102 and procalcitonin was 2.1. They sent the cultures and well, they're seeing like this blood work kind of like coming back and like getting like their suspicion higher and higher. They get a chest x-ray because she was like with the tachypnea and like the shallow breathing initially. And they could also like evaluate the actual clavicle, which was the main chief complaint that she had. And they had a prior x-ray from the day before. But at this time with the inflammatory marker, they were already pushing to get an MRI instead of the CT. So they get the chest x-ray. They read left lower lobe densities corresponding to soft tissue inflammation. I couldn't appreciate anything on the x-ray. And then they did the MRI of the neck, including the left shoulder, which has like findings consistent with like an infection at the level of the clavicle. She was given antibiotics and admitted like around 4 a.m. So ortho saw the patient while in the ED. They recommended the MRI. Banco and ceftriaxone were given. She was also like fluid resuscitated. So she got fluid as well. And the MRI final lecture was osteomyelitis of the left clavicle with associated cellulitis. So this is within 9:30 that she shows up to the ED, being admitted 4 a.m., 4:30 a.m. So when they're doing mornings on the floor, patient is transferred to PICU. Because at that time, she was still febrile. She had tachypnea and was having hypoxemia as well. So she was starting like 85% at rumor. She was tachypnic about like 55. They gave like some oxygen. It improved to 92%. So patient was just moved to the PICU. Once she was moved to the PICU, they tried to do BiPAP. The patient didn't tolerate the BiPAP. So she kept like getting worse and worse, worsening tachypnea, worsening hypoxemia. She went on and have like a tonic-clonic seizure, which they thought it was like due to the hypoxemia, because she decided like up to like 60%. It lasted like about 30 seconds. So after the seizure, they intubated the patient. Initially, she remained hypoxic despite tube confirmation. They began an epi drip, Versed, and fentanyl drip. So at this time, like ortho was already in the case, ID was already consulted. They consult cardio and neuro. Neuro, of course, because of the seizure. Why you guys think they consulted cardio at that time? There are multiple reasons, but we're like, so yeah, it was like endocarditis. So they were looking for vegetations, and also they were also, well, she was in cardiogenic shock. So they wanted to say like kind of like DF and all that stuff. And the other thought they had was like the patient, because she was like initially hypoxic when she was intubated, they thought like she might be having like septic emboli as well. So they want to have like everyone on board. So she's intubated, she's taken to CT. They do a head CT, which is negative. They do a chest CT. The final lecture was pulmonary edema. And cardio they do like the echo. Eventually, she doesn't have any vegetations. And neural eventually sees the patient and they do an EEG, which was normal. I'm showing this like this because I feel like this patient could have presented at any stage to the emergency department. So she could have even presented the, already like in cardiogenic shock, or like she could have presented with a seizure, or it was just like the respiratory failure, because everything happened within like 48 hours. She went to the ED, she returned the next day, and the next morning she was already in PQ intubated. So they can get sick pretty fast. She eventually did good. She was discharged, she's alive. We've seen her a couple of times afterwards for other things. So we'll get like to more of her like later on. So my topic will be osteomyelitis, right? Incidence is like 1.2 to 13 patients per 100,000 patients. It's most commonly seen on boys than girls. And 50% of the patients are gonna be less than 5 years old. Commonly affects the long bones of both upper and lower extremities. Clavicle is affected just in about like 1 to 3%, which is like pretty low. The mechanism for which you can get like osteomyelitis are the same as adult patients. Hematogenous spread is gonna be like the most common mechanism for pediatric patients. It can be also local inoculation for trauma or surgery, or also like spread from a soft tissue infection. When you're working up these patients, you gotta think about like infectious and non-infectious causes as part of your differential diagnosis. So part of your infectious will be cellulitis, septic arthritis, or septic joint, pyomyositis. Non-infectious will be malignancy, bone infarction, and vitamin C deficiency. In terms of the pathogens, same as adult, Staph aureus is going to be your most common pathogen. It can be like MRSA or methicillin like sensitive. It all going to depend on the risk factors of the patient and the prevalence of the community. You can also see strep pyogenes or strep pneumonia, especially if the patient has like chronic lung disease. Patients younger than 4-year-old, they usually get Klebsiella, and these pathogens specifically, they can present without fever to the emergency department, which is going to make the diagnosis like even harder. Non-vaccinated patients remember H flu, and sickle cell disease remember like salmonella. Risk factors, recent trauma. So it can be blunt trauma or penetrating trauma, any surgery or cath. So it can be umbilical cath, it can be a PICC line, central line, sickle cell disease, immunocompromised state, and systemic infection. That being said, more than 50% of the patients, you don't find an actual precipitating event or risk factor. And they usually will present with a fever, inability, or refusal to walk, crawl, or bear weight. They will have point tenderness on the affected bone with and without movement. So it's like kind of like pretty different when you have like something that's traumatic. And they can also like have like swelling and edema, but you are not gonna be able to see it on all patients. The good news is when you're working up these patients, your workup is gonna be the same for septic arthritis and septic joint. So you just gotta like think about all your differential diagnosis, and you're gonna be doing exactly the same for the patients. Your labs, CBC, usually white blood cell is gonna be more than 12, ESR more than 40, CRP more than 20, and you need to get your blood cultures because that's what's gonna like target the final like antibiotic therapy. Imaging, Initially, you're gonna get your x-rays because you're looking for fractures, malignancy, dislocation, other pathologies. You can get ultrasound if you think there might be like an effusion or if there's joint involvement. Plus minus CT, it all depends on what you have available at your institution, and then MRI, which is the gold standard. Patients, like pediatric patients, like a third of these patients, they will have osteomyelitis and septic arthritis, or they will have like septic arthritis and then get osteomyelitis. And this is all because of the physis. So the physis is open, they have a lot of capillaries in there. So they're gonna have a lot of like translocation of the bacteria. So you will see this like more commonly like on PICS patient, even more common on neonates, because then the joint kind of like extends towards the actual metaphysis. So x-rays, most likely you're looking for fractures. Malignancy, especially like Ewing sarcoma, this tumor can actually present with fever as well. And on the patient MRI, the attending was like, work up for Ewing sarcoma, but like given the setting and presentation, like osteomyelitis most likely, but like that was part of the differential diagnosis. The thing with the x-rays, they're negative for 2 weeks. In pediatric patients, it can take even longer for adult patients to actually get changes on the x-rays, so they're not that very helpful. If you do have any changes, are gonna be soft tissue, swelling, bone destruction, and periosteal reaction. Ultrasound, super low sensitivity for osteomyelitis. It's just gonna help you for joint effusion, or if you wanna find an abscess, like a periosteal abscess, like the one, it's like on this picture. So if it is like more than 2 millimeters elevation, that's also like, it's gonna aid in your diagnosis. CT, cortical destruction, gas, periosteal reaction, soft tissue infection, and abscess. And then MRI, which is your gold standard and your go-to if you can do this imaging. And these findings can be seen earlier than with any other imaging. So these two pictures are actually the same patient. This was like another clavicle osteomyelitis on a pediatric patient. The CT and the MRI were completed the same day. The CT was read as normal and the MRI was positive. In terms of treatment, you should start like empiric treatment right after you take the cultures. Within like our spectrum, we just have to do IV antibiotics. These patients they all get admitted. The length is going to be multifactorial. Usually it's between 4 to 6 weeks. Then they decide when to switch to PO antibiotics. They check if the patient is improving, if you're getting like blood cultures that are being negative now, and downtrending CRP, because the CRP is going to be that inflammatory marker that's going to like be high earlier than the ESR, and it's also going to start downtrending faster than the ESR. So that's like the marker they use for improvement and like response to therapy. Antibiotic treatment, I didn't go too deep into details. Up to they have like multiple charts, beautiful charts. But like basically like if the patient is septic, you do Banco plus nafcillin and oxacillin. If there is high prevalence of MRSA and the patient has any risk factors, Banco. But if the patient is not septic, if there is like high prevalence of MRSA but the patient doesn't have any risk factors, you can do Pinla. And if there isn't like a high prevalence of MRSA, you can do nafcillin, oxacillin, and cefazolin. So for our patient, it was suspected that the patient, she was highly colonized by methicillin sensitive staph aureus due to her recent eczema flare. Remember, she had like the discoloration on her skin, especially like on the lower extremities. So when you combine that exacerbation of her eczema and colonization of her skin, the history of like the minor trauma, and then taking into account that pediatric bones are highly vascular and that she had pain with and without movement, I think that was kind of like the perfect combination for her to get osteomyelitis. She was treated for 2 weeks with IV antibiotics, then they switched her to PO, they follow her outpatient. She did good CRP. They ended up like decreasing and like blood cultures were all negative after the first 2 positive results. Methicillin sensitive staph aureus. So when we see anyone with bone joint pain, it's most likely going to be MSK contusion. Kids fall all the time. They have like minor traumas. But just make sure like there isn't like any concerning history like factors. Patient has a normal physical exam. The patient has improved symptoms and doesn't have a temperature. If there is like a joint involvement or joint pain, then you gotta go and move towards your, is it transient synovitis or is it like septic joint? And that's when you use your culture criteria, especially if the patient has any temperature. So if they have low-grade fevers, white cell less than 12, CRP less than 20, MESR less than 40, it's most likely to be just transient synovitis. If any of this is altered, it's most likely to be septic joint. And then from septic joint to osteomyelitis and pediatric patient is just nothing. They're just one step apart from each other. Osteomyelitis is usually gonna have like higher CRP. Usually it's gonna be like above 100. This is a slide on neonates. Kind of like said some of the stuff before. I'm not gonna go into the treatment. Risk factors: premature, complicated delivery, skin infection, catheters, urinary tract abnormalities, and maternal infection at delivery. Pathogens are going to be the same for sepsis, so it's DDS, also coagulase negative staph, and syphilis. Symptoms: irritability, decreased appetite. They can or cannot have like any temperature. The thing is like the bones on neonates are even more vascular than older children. So, and the capsule actually extends to the epiphyseal plate. So about 75% of the like infants like less than 3 months old that have like septic arthritis or septic joint are also going to have osteomyelitis or vice versa. So you're going to be treating and dealing with both at the same time. This is going to be like a difficult diagnosis to make. So take home points. Physical exam, undress the patient. I don't know if, honestly, I don't think like a lot of things will have changed what happened on the first visit. Seems to be like a kind of like well-appearing kit, but there wasn't like any documentation of the skin. And she clearly had like some like skin colonization, like because of her recent flare and inflammation of her skin, especially on the lower extremity. We gotta undress our pediatric babies. Even if slightly abnormal, be careful with your abnormal vital signs. Temperatures initially were 100. That wasn't a rectal temperature. Maybe if they would have done like a rectal temperature, she would have been febrile. Maybe they will have done a workup, maybe not. But it's just like good for thought. Things that you gotta like think about. Don't get comfortable because most of the time it's nothing. But then when it's something, they can just have septic shock within like 48 hours. And return precautions because they can actually save lives. So this patient actually got great return precautions. They were documented, and mom actually was pretty proud and brought the patient back to the emergency department. These are my references. And any questions?